and welcome all of you to, again, our final ECHO-TIE session of the 2024-25 school year. It has been our pleasure to bring you exciting presenters, and today is no exception. I am thrilled to welcome Lori Potts from Rifton. Lori, I'm going to go ahead and let you begin. Introduce yourself. I could not do justice to you. Please tell us about what's in your memory bank and share with us about pediatric adaptive standing. Lori, I think people, if you want to raise your hand or type your questions into the chat, we will address those at appropriate times, and Lori will leave plenty of time for question and answer. So I'm going to stop talking and invite Lori to start. Thank you for being here.
Thank you, Deb, for that wonderful introduction. Kudos to ECHO-TIEs for all that you do. And very happy to have this opportunity to talk about pediatric adaptive standing. So welcome, everyone. So my name is Lori Potts, physical therapist. I am a product and training specialist with Rifton. I do want to say that this particular presentation is not a promotion effort from products. It's describing standing, the value of standing and features of standards that benefit, and will include photos from other manufacturers, and I send out my appreciation to all of them. All right. So we know there are many valuable benefits of standing, and not all of them will be included in this particular webinar. What I wanted to focus on is engagement with standing in the school-based setting and how we can educate classroom aides and teachers to understand the value of standing and to onboard with implementation of standing. So for those reasons, we're going to be focusing on 3 research-based benefits that you see here, as well as talk about participation as a goal with adaptive standing. And then we'll end with our case story. So as we think about standing, let's remember that it's simply one part of the whole picture. And we're looking at outcomes. Granted, it's an education-based environment, but we're still concerned with their learning in terms of motor skills. With immobility, what happens is there's this cycle of a sedentary lifestyle with the musculoskeletal detrimental secondary impairments that follow on that. Whereas when we have an activity and participation-based approach, we can promote physical activity, incorporate postural management, and task-oriented intervention in a way that is actually going to engage that motor learning and increase that participation. So standing is part of that. Now, postural care is a term coined over in Europe and Australia. Here in America, it's more commonly known as postural management. But what we're looking at is the positions that a child is in during their day, standing, sitting, supine, in a 24-hour approach. At the same time, we're seeing current 24-hour activity guidelines for both typically developing and children with disabilities that consider their physical activity, reduction of their sedentary time, and their sleep. So we can actually meld these into a 24-hour approach and see how standing is part of that picture. So the goal with a 24-hour approach is ultimately reducing the risk of musculoskeletal physiological damage over the long term, reducing fatigue in terms of enabling children's day-to-day task involvement without excess energy expenditure, and ultimately enabling the child to be as independent and to participate as much as possible. So if we think about this upward cycle as our end game with our 24-hour approach, we can then recognize that standing is a part of that whole. So we have standing as a change of position, vertical, walking supported walking in vertical, and both of those in that physical activity realm. Then there's sitting on a tricycle, also physical activity, but sitting in daily activities that are then done in such a way that it promotes symmetry and prevents skeletal distortion, up to and including nighttime positioning. So let's now take our first topic, physical activity. We want to dispel the myth that placing a child in an adaptive stander is not passive. It is physical activity. And to refresh our memories on physical activity, we want to think about the metabolic equivalent, or METs, which is that unit representing the oxygen consumption of an activity. And 1 MET is required when a person is resting or sitting still. So an activity that's greater than 1.5 METs would require more energy and would then be considered light activity. The World Health Organization absolutely is extending parameters in terms of levels of intensity of physical activity and encouraging moderate to vigorous physical activity. Now, for our particular population, this can be more of a challenge to achieve. This is a study by OTAP-RSOI and his colleagues out of the Netherlands, and they analyzed the time spent in physical activity of individuals with cerebral palsy, looking across all gross motor function classification system levels. So level 1, these children are ambulatory. Level 5, they're non-ambulatory. And the first set of bars is sedentary behavior. And what we're seeing is that across all GMFCS levels, upwards of 76 to 99% of their waking hours are sedentary, with GMFCS level 5 the most sedentary. The next set of bars is light physical activity, and the third set of bars, moderate to vigorous physical activity. And here at the moderate to vigorous physical activity, we can see that levels 4 and 5 are not achieving that at all, which we fully understand by the fact that they are non-ambulatory. So this gives us pause. How can we intervene for this population? What we need to recognize is that we can see value in light physical activity. Sedentary behavior in and of itself is detrimental to health in terms of physiologic consequences. Light activity is interrupting that sedentary behavior. So even if we're not achieving moderate to vigorous activity, we are increasing the child's energy expenditure and promoting their health and well-being. So this is a systematic review by McLean, published in 2023, making the statement that supported standing is not passive and may provide an important psychosocial, but also physical change of position. And that systematic review sourced these 2 studies for that statement. The first is 19 children aged 4 to 20 years across all GMFCS levels, and their energy and muscle activity were measured when they were lying supine, when they were sitting with support. Oops. Sorry about this. Let me just quickly do that for us. Thank you. So, right. So they were measuring energy expenditure and muscle activity in different positions and postures. And one of those was standing. And they had elevated energy expenditure in standing. And I think we as practitioners recognize this. When we place a child in a stander, we notice their breathing rate may change, their heart rate may change initially. Even just that position change is effortful to them. Similarly, here we see another study, and this was here we come. These were, again, children with GMFCS 4 and 5, cerebral palsy, and they had a higher number of children involved in this particular study. And as they were measuring their heart rate and heart rate variability, they did establish that in passive standing, those values changed and increased. So that suggests to us that this activity for these children can almost be a form of exercise in terms of influencing their physiology and their tolerance for standing over time. So this is again from Verschuren, specific to cerebral palsy, the FIT principles, frequency, intensity, time, and type. We want to break up sedentary time. He was recommending even every 2 hours a day, interrupt sedentary time, and break up sitting for even 2 minutes every hour, which we could see as potentially done with a sit-to-stand transfer. And then ideally also reaching that moderate to vigorous physical activity for an hour across the week with a variety of activities. World Health Organization, similarly, for all children, including those with disability, again, 60 minutes, moderate to vigorous intensity, mostly aerobic, physical activity across the week. Where that is out of reach, let's at least limit the amount of time being spent sedentary, reduce recreational screen time. Doing some physical activity is better than none. And here is a nice resource. Some of you may already be familiar with it. The National Collaborative on Childhood Obesity Research. They take 196 common activities and provide the MET value. So this will be a good read for you, whether the activity is light or moderate or vigorous. And as we see there, standing, depending on the age of the children and depending on what they're actually doing while they're standing, we can increase the METs even beyond 1.5. Now, granted, this is not standing in a stander. However, for our population, being placed in a stander gives them a similar light physical activity opportunity. So that is our first benefit. Adaptive standards can help us to reduce sedentary time, i.e. physical activity. So we're progressing them to light activity, and we want to schedule those intervals of standing throughout the day. So we're going to need to get the buy-in from our classroom staff. Our next topic is postural management. And we do know from the research that adaptive standing impacts postural asymmetries as well as hip migration. You knowing this will help you to convey this information to parents and teachers. With our systematic review, McLean, we know maintenance of bone mineral density. That's understood in terms of the value of standing. We're not discussing that in depth today. Can help reduce fractures, but also contracture prevention outcomes are supported by the most experimental studies and evidence syntheses. I will not review every article in the review today, but we will look at some of the research. So where are we in terms of prolonged posture? As these children don't have the opportunity to change their position during the day, we see tissue adaptation and ultimately contracture. The current preferred term rather than deformity is distortion. And similarly, the current preferred term is non-reducible rather than fixed. But that is when the joint is limited in its passive range of motion and cannot be ameliorated except for with surgery. So this is an outcome of asymmetrical posture over time. This researcher states a small knee contracture can be the start of asymmetrical posture. And in the end, that wind swept position where one leg is abducted and externally rotated and the other internally rotated and adducted is then a risk for continuing hip and spine problems such as dislocation and scoliosis. So we need to be conscious of that early beginning of that knee flexion contracture with this population. Postural management or postural care is assessing and providing equipment to support symmetrical positioning, and it encompasses that symmetrical positioning in sitting, standing, and lying for that functional symmetry, thereby negating the risk of these sort of postures and over time then reducing health risks and improving quality of life. So in Sweden, they have a national surveillance program, and all children with CP or at risk for CP are registered before 5 years of age. And researchers can access and review all that data for a longitudinal study. And here we see a study done where more than 2,600 children at all GMFCS levels their records were reviewed to determine when and at which joint their first contracture appeared. Contractures were found in 34% of the legs. The little diagram there from Canchod, Canada is just a reminder of GMFCS 1 through 5. I enjoy the diagrams there because GMFCS 4 and 5 actually show a standard for those kids. But here's what happened in Sweden. Here are the data, the results that they found. Those children who were ambulatory, the first contracture occurred at the ankle. We can picture them walking in a toe walking type gait. Those at GMFCS levels 3, 4, and 5 who spent more time sitting, their first contracture was at the knee. There was a follow-up study looking at the data more specifically. And what they found was that they were looking again, sorry, I'm going to back up here. They were looking at over 1,000 children, again, all GMFCS levels, to determine where the second contracture occurred. Over 40%, close to 50% of those children developed a second contracture. And the frequency of the more than one contracture was occurring at the higher GMFCS levels. Actually, same was true as the first contracture was happening at those higher GMFCS levels. Those are the kids we really need to look out for. So here's what they found. If the first contracture was at the hip, the second one happened at the knee, at the adjacent joint. If the first one was at the knee, the second one would be at the hip or ankle, again, the adjacent joint. If the first one was at the foot, the next one was at the knee, again, the adjacent joint. So either way, be it the first or the second contracture, it's happening at the knee. So,
Laura, we have a question if you'd like to address.
Sure.
Okay. And
is
Jean,
it in the chat?
Yes, it is. And so, Jean,
Okay.
you can unmute yourself and pose it, but can you see the chat, Lori?
Okay, yes. Thanks, Jean. Yes, there are. And those studies relate to bone mineral density. So currently, Rifton standard has not been designed to be incorporated with a vibrating movement platform. But it's definitely something that we're keeping our eye on in terms of the growing research. And that dimension of research won't be included in today's presentation, but thank you for bringing it up. And the potentially the old style Rifton standards, if you have an old style prone or Rifton standard, you can slip off that foot plate and set up the child over a vibrating platform, but it's not designed in with our new standard. I hope that answers your question. Did you want to speak from your experience?
I didn't mean to interrupt.
No, that's great.
But yeah, I'm holding a child over this vibrating plate because they did this therapy in Texas. So, you know, it's kind of vigorous to hold the child on there. So I thought, oh, if I could wheel his gait trainer, but then that didn't work, or a standing frame over the top or something.
And I'm not up on all the recent research with the vibrating platform, but I do know there's also consideration that it may engage some of the smaller muscles, postural muscles that are otherwise hard to access with other means
It
of intervention.
engages mine when I stand on it, for sure.
For sure, for sure. So,
Thank you.
good point. And anyone, please feel free to drop a comment in the chat, and Deb can, make sure those get incorporated as we go along. So then another study published out of Sweden with that Swedish National Follow-Up Program, and measurements are taken twice a year up to age 6 and then once a year beyond that. So they were looking at data from over 2,000 children from 0 to 18 years of age at all GMFCS levels, and without question, what was happening was children with severe postural deformities were getting more musculoskeletal asymmetries with 12 times increased likelihood for knee flexion contracture. So we need to have our eyes on these kids, and we need to be intervening to ameliorate this or prevent this. All right, another study. Again, making use of the data from that national CV registry in Sweden. They reviewed 2,800 children, and they were looking at the degree of their knee flexion contracture and comparing that with functional mobility scale assessments. So whether their child is walking independently or using an assistive device or a wheelchair, so their standing and their walking ability. And here's what they found, that the more severe the contracture, the greater the impact on functional mobility. And here's a visual where we see the green bar, the child has less than 4-degree knee flexion contracture, essentially no knee flexion contracture. The purple is very severe, greater than 15 degrees. The top of the chart, you can see those children with severe knee flexion contracture are unable to stand. And at the bottom of the chart, you can see that those with no knee flexion contracture are transferring without support. So underlining this significance of both preventing contracture, but also identifying the children unable to stand on their own, getting them up and standing to prevent contractures and keeping their potential future mobility options open. So this case study was published in the McLean Review, and it's a 16-year-old male, spasticity, contractures in all 4 limbs. The goal of the researchers was to do standing 90 minutes, 5 days a week, but in reality, due to real life and circumstances, it averaged out to 3 times a week, 60-minute per session. But even that said, over 15 months, they were able to gradually increase knee extension, hip extension, and the angle of inclination to more upright. And they took these measurements, and here is their outcome. On the left-hand side, we can see the right hip started out with a 25-degree flexion contracture. 15 months later, it was at neutral. The left hip, a 20-degree improvement in range. Knees on the right, also 20-degree improvement in range from 40-degree flexion down to 20-degree, much more extension. The left knee flexion remained essentially unchanged. And there may have been considerations with the positioning and the level of spasticity, and consider the gains made on the hip on the same side. So all that said, considering he's 16 years old, this is a remarkable level of improvement. And not only that, but subjectively, his activity and participation increased, his pain reduced, and his bowel function improved with this regular standing. And I did want to share a picture of the individual, his initial baseline posture, and then showing how much more vertical, how much more extension at the joints after these regular 3 weekly 60-minute sessions. He's even happier and tolerating standing as per the photo after those 15 months. So next, I'm going to just show a video with Rifton's new standard as an example, showing the potential for hip.
Here at the hip, we have a knob that we can loosen that allows us to bring the hip forward up to 45 degrees of hip flexion. And as we're hoping to stretch that, we can open it up a little. We might start with a little more angle than we need. As the child relaxes, we can stretch. Here at this knob, we have knee flexion. And again, even within one standing session, we can hopefully encourage some stretch. So that is available on the size 2. If we start young enough with early intervention, we might prevent the development of contractures altogether if we can stand regularly in a fully extended position.
So let's extend this conversation and discussion from extension at the joints to also thinking about abducted standing. And if we remember, the hamstring and gracilis muscles cross the hip and the knee. So an abduction position is going to provide a prolonged, gentle stretch to both of those muscles. Now, here was another study. And again, data from the Swedish registry. What these researchers did was they took children who had been enrolled in the registry before 2 years of age and followed them over a 7-year period. And all children were placed in their standers 10 hours a week. These were all children at GMFCS 4 and 5. So the left column that we see is the study group. They were placed in abduction. S group 1, S1 had that standing position after a surgery to release their type psoas and adductor muscles, whereas group 2 stood in abduction without surgery. Both control groups, group 1, were in neutral standing. The numbers are more in that group because there simply were more standers that had neutral standing position at that time. And here are their outcomes. The study group, no child developed any further contracture through that abduction standing. Whereas in the control group, from the 39 joints that initially had contractures, over that span of time, looking at all the data, it increased to 80 joints. This is specifically adduction and knee flexion contractures occurring in these children. So something about that abduction standing has value in terms of contracture prevention as well. And if we look at standard features, we want to consider that 0 to up to 30 degrees, which is reflected in this study, but of course you're going to do to the child's tolerance, and potentially doing that adduction even within a standing session, managing to increase that a little more as they tolerate. The other consideration around abduction standing is hip migration percentage. And that is looking at the amount of the femoral head that is not covered under the acetabulum. So the segment A is not covered by the acetabulum. The larger that MP number, the worse the dislocation. If that number is 100, it's a complete dislocation. And these researchers in 2022 determined that that migration percentage, as well as the rate of change of that migration percentage year to year, that is your predictor of eventual dislocation, even more so than the acetabular index or the hip shaft angle as shown on the other side. So we're going to hone in on this migration percentage, and that is what these same researchers looked at. On the left-hand side, we see the study group. These children stood in abduction. Study group 1 had hip surgery, the release to those tight muscles. they had an 18% decrease to hip migration, more coverage of the hip. Study group 2, even without surgery, had a 7% decrease to hip migration. Whereas standing in neutral, there was some decrease after the surgery, but in the case of the children without surgery, there was actually an increase in migration percentage. So this definitely gives us food for thought. And in the researchers' own words, their theory is that as abduction increases, the load on the acetabulum increases because the total body weight is resting on the femoral head that's now covered by the acetabulum in that position. Adductor muscles are also in a stretched position, further pressing the femoral head into the socket. So it's that weight bearing that's deepening the socket of the acetabulum and providing better congruence over the head of the femur and reducing the migration percentage. So we're actually having an impact on the bony formation, which is why we need to start this very early. This is another study that just counters their findings. It's from back in 2010. This was an experiment, if you will, or an attempt at an intervention where they, instead of just having an ankle AFO, they actually had a total AFO to put those knees and hips into maximal extension. But what happened? They found that this standing shell intervention attempt in the end did not promote bone mineral density, and we can surmise that they weren't properly weight bearing or engaging their muscles in such a way as to promote osteogenesis of the bone. But at the same time, migration percentage worsened. So this is neutral standing, worsened hip dislocation as shown on X-ray. And we can only wonder that possibly, let's imagine that this is your femoral head and femur, and you have your adductor muscles, very spastic adductor muscles, that this neutral position ends up acting as a bit of a fulcrum and promoting migration percentage increase, and or just not achieving a decent coverage and weight bearing to alter bone growth in the hip socket. So this is a international clinical practice guideline by Morgan and colleagues. And they are recommending prevention before age 2. Begin this adaptive standing early and in this abduction position to potentially decrease hip migration percentage. And we could add potentially prevent contractures. So we're looking at early start to adaptive standing, but there's definitely benefit in the school age as well. Even after the socket has formed, some abduction is going to add stretch to those muscles that cross the hip and knee. So definitely consider that abduction position. So Deb, definitely let me know if there's any more chats that I can respond to at any point. Otherwise, we'll kind of wrap up this segment by saying that here are evidence-based clinical recommendations around standing. Many of you may be very familiar with the Ginny Paleg article from 2013, and now we have the McLean in 2023. And discussing both the hip stability and the joint range of motion, we are looking at an hour of standing. This would not have to be at the same time. So you could consider standing for shorter periods of time at intervals, making sure that it adds up to a total of 60 minutes of standing. And then we need more research, but certainly qualitatively, we're seeing improvements in respiration endurance, decreasing pain, improving bowel and bladder. And I'm sure many of you have anecdotal stories that discuss those benefits. And if anyone wants to just take a quick photo of this, these are the systematic reviews. You do have a full reference list in your handout too, but these are great articles to go back to in terms of justifying standing from the medical standpoint, and convincing administration of these benefits for your students. So potentially preventing contractures and hip migration as part of postural management, and doing so by leveraging their growth spurts. When their bones are growing, we want to make sure their muscle growth keeps up with that. And we can do that by making sure the muscles are extended to their full range regularly. And that is kind of our summary slide for this. So shall I go ahead and
we do have some questions that have started to come in, and I can certainly read those out loud, or you can also look at them.
Yes, so thank you, Deb, for mentioning that. If we're not
I think
focusing on
people were just
solving-
waiting and not wanting to interrupt you, but this is a good time for everybody to think about what are your questions. And we start with Kelly. Ideas for prolonged standing for a child with significant dystonia who doesn't tolerate being strapped into devices. What ideas do you have?
That is a challenge. And I think a key is going to be identifying, trialing a standard that is optimally as comfortable as possible for the child. It may mean that if in the case of a child who does already have contractures, that you accommodate those first and then only begin the attempt to ameliorate the contractures over time, slowly. But just the value of being upright in that physical activity benefit, physiological change of position is a place to start, even if you only move toward vertical gradually as well. So
at this point, this is a 4-year-old. She has not developed any significant contractures yet. I have tried a number of devices. She really doesn't tolerate having her feet strapped in. She's got to be able to have some body parts that can move. So a stander, I have just not come up with anything good. What I am using is a Puma body weight system so that she can get some weight bearing, but I don't get any prolonged weight bearing. We're not anywhere close to getting in the kind of time she needs to be up on her feet. So I'm always looking for ideas because she challenges me all the time.
Great. Yeah. I'll say, without sounding like this is an infomercial, sometimes the standard selection and the positioning can place you toward a win. But then it's also going to be what she's doing while she's standing and not having great expectations in terms of time at first, but more thinking about place and occupation to make it. I don't mean length of time of day you could certainly consider, to make it as positive of an experience as possible. But the adjustment on the hip and knee flexion can also be done in prone. So accommodating into a more comfortable position initially to accommodate to the device, even if it feels a little bit like kneeling almost, till they are happy in it. The first achievement is to be happy in the device and then to position it for the physiological benefits.
Did that help, Kelly?
It just means I have to keep trying things
Well,
because
that's
I
right.
can't.
I wonder
She's
how
in
much.
a Rifton.
Go ahead.
She's in a Rifton activity chair, and I can use the harness and the seat belt. I cannot strap her feet in, or she is not having it.
And I just wonder about motivation and activity, and what other things are going on, and does it distract her enough? And it sounds like she's so sensitive that those things may not matter. So
Yeah.
all right.
We'll just keep working.
Well, that's right, and that's persistence is part of your trade, isn't it, Kelly?
Yes.
Small growth is still growth. I see a question from Mary Ellen. Of course, we're talking about school environments, but Mary Ellen has a question I wondered about. Has this also been studied in the adult population?
There definitely is a lot of standard research with the adult population. I'm not sure about specifically improvement of range of motion in terms of amelioration of contractures with the adults. That I couldn't tell you. There may be research out there, but I haven't focused on that yet. But definitely there's a lot of research. So I would look to Clinicians Task Force and RESNA for their papers on standing in the adult population and see what you can glean there. As far as Kathy Baupain's point on standing over the age of 8 in terms of bony formation, I've heard this from other members of other audiences. I have not been able to identify that study yet, but the one study which I reviewed today, they simply didn't follow the children for longer than 7 years, so they just don't know. But it would certainly seem that after maturation of the bone, it would be less likely to deepen. The exact window in terms of age would relate more to the growth plate. But I definitely see abduction standing as having value in terms of that contracture management as well, to where it's tolerated, to where the space is available in the room. I mean, obviously your tallest adolescence is going to be less feasible, but I do see value in abduction standing, even though we don't have the research beyond age 8, or I haven't seen it. Thank you. This is really a wonderful audience, very engaged.
Yes.
And what I'll do now is move on to our trunk control topic.
Thank you.
And again, continue to feel free to post questions and comments in the chat. So here I do have to frankly say, we do not have a lot of research yet. That's why I'm posing this as a question. Can adaptive standing impact postural control? It's definitely a consideration to explore. And as we look at this, postural control is the ability to maintain balance in anti-gravity postures. So it's a primary impairment in young children with CP. And if we think of it as controlling our bodies above our base of support, holding and adjusting a specific position for a task, engaging with a task with the environment and that stability. So these research studies were done with typically developing children, and I won't go into the data from the research. The references are available to you, but they did find a correlation between core strength of these typical infants and their gross motor development. So those with more trunk control were shown to demonstrate earlier gross motor development. And so these researchers are stating this is an area that we need to also focus on with children with disabilities. Many of you may be familiar with SATCO, which looks at postural control in static position, active position, and reactive. Whether you're simply able to align and maintain the position or hold that alignment while turning and reaching, turning your head and reaching, or even after a brisk nudge, maintain or return to upright. And this is the test position. So the strap system is aligning the thigh and pelvis, and the manual support is placed at different levels going up the trunk. And here we can see these 7 levels in effect, with no support being full trunk control and support at the pelvis reflecting the trunk segment of lower lumbar. Now, for children with mild cerebral palsy, we could anticipate them needing lower support, whereas children with severe cerebral palsy needing higher support. And this indeed was reflected in this one study done in the seated position, where children were classified as having mild, moderate, or severe cerebral palsy. According to this SATCO classification, they did these arm movements and did kinematic data and found that for those children with mild CP, the level of support actually did not have an effect. Like you could provide more support and they could still function. But for children with moderate CP, if you only supported at the pelvis, there were decrements. For children with severe CP, they needed support up at the axilla because that mid-rib support resulted in decrements. So what we're saying is, if we can provide adequate support, but not too much support. So we don't want to make them dependent on too much support, but we do want to match their intrinsic level with our external support and then reduce that support where we can, certain activities or short periods of time, to potentially build trunk control. And we have to admit, we don't have a lot of extensive research in this area yet, but we do have a case report of a child in Western Africa. And this child had HIE and cerebral palsy, and at 8 months old was placed in a very simple constructed supine stander with support at the chest and knees, and initiated an 8-week standing program. This was their only intervention, but they did it very consistently. It went so well that for the final 3 weeks, they actually went up to 60 minutes a day because the standing was progressing so positively. GMFM-6 was taken at assessment and at post-intervention, and the GMFM-66 scores increased from 28 to 37.4, improved head control, improved upper extremity function, improved sitting ability, improved motor function. And, you know, we might argue, could some of this have been a reflection of just their natural course of development? But considering his diagnosis and his ability level at 18 months, we can credit this to some degree to this regular use of this standing opportunity, which will now impact his long-term prognosis. These two studies following are retrospective. So this is looking at older children, 1 to 14 years of age, different types of CP, and testing them for both function and for trunk control, SATCO. And we see also in this population, those with better trunk control are demonstrating better gross motor function and mobility. And that was correlated or corroborated by a completely separate study, completely different researchers. 58 children with spastic CP, functional abilities were assessed, trunk control was assessed, this time using the TCMS and the the trunk control measurement scale and the trunk impairment scale. And those scores were analyzed. And again, they found this correlation. So they were saying that even just by assessing trunk control, we can have an idea of their functional ability. But to us, this says we need to work on improving trunk control with these kids. And there are ways to do that. We can, over time, reduce head support. We can reduce anterior support of the tray. We can look at moving the trunk support higher or lower. So this correlates then with your SATCO. We can think about where the trunk supports are placed. The trunk strap has 2 slots, and there's also 2 styles of both hip and trunk straps. So which one gives firmer support, which one you could loosen to provide a little more challenge. These are the ideas here. So let's take some questions from the chat, and then we'll quickly talk about participation and then leave time for our case study before we wrap up.
Well, I see
Okay.
Pete asked a question and someone else kind of responded to it.
Okay, excellent.
Equipment.
Oh, good. Yes. So you're familiar with SATCO and then standing and gait training. Yes. Yes. Yes, all good comments. Definitely all decision making. You know, where budget does allow both a gait training and a standing device, of course, the standing device will actually really provide that stretch at the hip and knee. But at least any dual gait training and standing device will give you that weight bearing and upright position opportunity and participation opportunity, which leads us to this next topic.
And then Marnie just posted a question.
Okay. Yes, thank you. Okay. Yes, AFOs, very key. Sure I see them properly. That is a challenge. That is a challenge. Yes, I don't know of research or guidelines, so I think it's going to be definitely a clinical judgment situation where using a supportive shoe or adequately bracing the knee, and just assuring that your position is as optimally aligned as possible is going to be what you'll do until you can get those AFOs. Okay, so participation. Adaptive standing provides that opportunity for participation. So these are, again, clinical practice guidelines talking about child-centered approach, making sure the child is comfortable, enjoying the intervention, and supporting families to embed those opportunities into the day. So we think about that standard selection in terms of ease of transfer, ease of adjustment of components, getting the child at floor level with their peers or to a higher surface to access their environment, and then adjustment and adjustability in terms of maneuvering, indoor, outdoor, and easy push-pull handles. So because of this important position change and function and social participation, and we also want to enable the child to have their choice in when and where to stand, we need to brainstorm with family and parents in terms of when that standing can happen, when it can be organic and fun or functional. Some children may find their either feeding or self-feeding opportunities work better in the standing position. It could be built in with things that happen regularly in the day, finding ways to incorporate standing at home and then as well at school, which definitely will take that team around the child and that education piece of those adults who are with the child when you are not there. So here's an example of a child schedule from an actual program. And you can see at period 8 is music and movement. On Mondays, he does do that in an ambulation device, but on the other days, he's placed in supine standing for music and movement. So they've engaged with the teachers and it's understood that this is the expectation for when that happens. So we want to plan and coach, remembering that a goal without a plan is just a wish. This is an example of one program, again, where they actually take a photo of the child, in this case, standing in a gait trainer, and explain what the expectations are, how that will happen, and make sure there's follow through. And Rifton does actually offer a positioning protocol instruction, fillable PDF, which you can access, that allows you to put in the name and the positions and the supports, and even a photo of the student, so that this follow through happens. So that's key, increasing participation. Having said this, what we'll do now is introduce our case story and think about how we're going to implement the evidence that we've discussed today, recognizing it as current best practice, scheduling that standing throughout the day for physical activity, breaking up sedentary time, minimizing contractures or hip migration, and then supporting potentially trunk control and function, making it purposeful and meaningful at the same time. So here is Robert, our case story. Deb, is this fine if I jump into this, or do we have another chat question?
No, I think we're good. Go
Okay.
right ahead.
So here is Robert, and we will state Robert's story, and then we'll look at these 4 discussion areas from this morning and just have your participation in terms of ideas and thoughts you might have. And then when Deb notifies me to do so, I will then go through my slides to kind of finish out today's presentation. So Robert is 10 going on 11 years old. He loves his dog, Ollie, who is a golden doodle, and Ollie loves him. Actually 3/4 poodle and 1/4 golden retriever, but nonetheless, he lives in upstate New York. His diagnosis is HIE and CP, so he's GMFCS level 5. And he first began standing at 11 months of old. 11 months, he was 25 inches tall at the time, began using an adaptive stander regularly. At 4 years, he had surgical implant of baclofen pump to manage muscle tone. He did have right hip surgery and he did have left hip surgery, and notice that his stander did not accommodate for abduction. So we could question whether, had he been standing in more abduction earlier, would that be the case? But nonetheless, he does not have any lower extremity contractures through his regular standing, which is a considerable achievement. So given this little window into his status, I would like to hear from any of you your thoughts on a student, 10 going on 11 years old, GMFCS level 5, no contractures, but certainly still requiring postural support and non-ambulatory. In what ways might we engage with his school and class to promote physical activity, ongoing postural management, potentially even some postural control gains and participation? So I'll just give a minute or so here if anyone from their experience with students with cerebral palsy GMFCS 5 in the classroom would want to speak to how this might play out.
I see Jennifer has a comment. STEM classes, art, PE, opportunities to be in standing. Do you want to elaborate on that at all, Jennifer?
I think what Jennifer says there is definitely key, is identifying the opportunities child's schedule that would offer those opportunities.
Mhm.
So that's a beautiful first step.
And looking at the child's likes, what it is that they like to do, and motivating the STEM classes, art, those are all pieces. Jennifer, I saw you unmuted. Did you have anything else to add there?
Well, the next challenge, of course, is getting the buy-in from the actual teachers and having, especially in PE classes, activities that are accommodating to our students in standards.
Very important. The whole concept of moving beyond identifying where, when, and where the child could stand to who and how will see to it that that happens. And definitely in school-based practice, that role of the therapist, of that team advocating and the team around the child and the education piece.
So Leslie has a comment. If they're able to pull to a stand and stand, the use of a stand will still be recommended.
Okay. Again, clinical judgment. But we did see with our postural management data that even children at GMFCS level 3 were getting contractures. Also, there is research around spasticity reduction. So it would be very child specific. And again, if it's comfortable, positive, and engaging in terms of participation, but definitely there could be a place even for a child who is able to move from sitting to standing to just spend time in a stander as that prolonged stretch benefit at the knee, preventing development of contractures from early on or ameliorating existing contractures to some degree. Consideration around that research-based intervention.
So I see you're looking at the other two, Sadie and Kathy's comments. People are adding.
Oh, yes. Yeah, excellent. Good. Yeah, hopefully everyone can see those thoughts and read those. That's definitely
More comments than questions.
yeah, but it's so valued in terms of
Absolutely. And Kathy, your comment about needing two people, that's just that basic need sometimes is hard to fill.
So hopefully this presentation and the research list equip you to educate your staff and get their buy-in. Go ahead and unmute and pose a question if you'd prefer to do it that way.
So I think Sadie has a really good question here that didn't get answered. So for the higher level kids who are able to ambulatory, should you still try to have a standing frame program? Because I think we all can agree treadmill training for those kids has definitely clearly shown, gains in that, but it doesn't address, treadmill training does not address contractures or quality of gait necessarily. It's just pure walking. And so, yeah, comments on that?
Good. So your decision making is going to be very child specific, and it's also going to be made in the school-based practice environment. So it's about engagement in their education from that standing position. Now, the value of standing, even for children who are GMFCS level 3, is interrupting their sedentary time, giving them more opportunity for being physically active, even if it's not moderate or vigorous level. Prevention of contractures, and that again is going to be your individual assessment. And then potentially improving upper trunk postural control, either better function by the fact that they are in a supported standing position for their upper extremity activity, or using that positioning to gain postural control over time. So will the child themselves buy into spending time in a stander? Can it be conceivable within the school-based practice context? Yes, in terms of research-based practice, standing has an application for GMFCS levels 3, particularly if they're at risk for contracture. But it's going to have to be child-specific with your IEP goal, your parent-driven IEP goal, and improving the quality of life and improving the child's educational experience from that standing position.
This is Sadie here. Sorry, my video's off because I'm driving. I'm gonna go to work.
I'm sorry.
But my question specifically is, in those levels 1 and 2, is there any research that prolonged standing would help them? I'm thinking kids who are pulled maybe for short group or for small group study, and that's a time when they could be standing doing some of that small group work. Because I know that the passive stretching, standing there for 60 seconds and stretching your calf isn't going to do much for those kiddos. But will that prolonged, if I could have them in it for 30 minutes, 60 minutes during a small group educational setting, would that make a difference in the contracture management for that child?
Again, yeah, we don't have the research. So
Don't have the research. Okay.
but, the AFO use and the weight-bearing standing in combination, kind of from clinical judgment, you would imagine to be valuable. However, getting a child who's GMFCS 1 and 2 to spend time in an adaptive center could in itself be a challenge. So you're just going to have to balance what is realistic and doable. But certainly across the board, the standing position, just like people who work in offices are recognizing that standing at their desk is going to benefit them over time. We could find ways to engage children in the school setting in standing, and whether that's in a device or not, or how you do that, I would say support that concept.
So Lori, we have just 4 minutes left, and I know you want to talk about actually what was done with Robert. So
right.
Let's go ahead and move there.
Let's go through that. So in terms of adaptive standing physical activity, scheduling the standing in the day. And this is actually Robert's first time in the new Rifton standard. And he did very well, but definitely heart rate and breathing increased, and standing time tolerance increased over time. So it was a matter of sitting down and brainstorming with his team, looking at his schedule from when he arrived to when he was dismissed, and actually planning when the standing would happen, knowing that there would be up days and down days, knowing that there would be days when it worked and when it didn't, but building in those opportunities so that it was more likely to happen than not. And teaching the staff how to do the transfer, which is another key. So this is just showing the stand pivot transfer by his classroom aide, Monica, and we'll just watch that there.
Video shows Monica, Robert's teacher assistant, helping Rob transfer into the stander. You'll see she checks that the gait belt he is wearing is snug and that the stander has the wheel brakes secured. And then she encourages Robert to participate in the stand pivot transfer. And when Robert is comfortably lying on his back, she can make sure all the positioning supports are secure. Let's watch this transfer. Great job. Can you tell how Monica feels empowered in her knowledge of how to do this right? You may have noticed that at first she had the legs positioned with some hip and knee flexion so Robert could relax his legs initially. I didn't show in the video how she then fully straightened the legs as she was securing the leg straps, but she is an expert with this. And she can also adjust the height of the stander to make sure he can stand more vertically at pier height. And she doesn't mind how long this takes because she genuinely enjoys the time with Robert.
I do think that is a key element is kind of getting over this idea of it's going to take time to do that. In terms of the child's day, they don't mind the one-on-one attention. So once the carer
Video shows
realizes that this is how you're using your time. You're doing something very valuable and something that you can do well. That sort of changes that dynamic a bit. So here's a closer look at Friday. And here, the standing is anticipated. So he's in his stander before the OT arrives. Or if they know that they're going to do the standing for lunch that day, he's in his stander just before that time. So it's a matter of building it into the day and anticipating and knowing that you're going to use that time for this. So then that brings us to postural management. And there again, it's that education piece of the adults around the student. So teaching them how to do that adjustment to bring the legs out into abduction. And then in this case, this is a little lead into the discussion around head control, also teaching them for just intervals to decrease support and use manual support at the back of the head to increase that, work on that head and trunk control. So leading into that discussion, we can see how over time, and this is over a year and 2 months, so 14-month period, we can see improvement. Now, granted, the February shot is a snapshot. It's not like he's doing that for long stretches of time, but he can do it. So really believing that with opportunity and with intentional positioning, we can see improvement in trunk and head control. And then finally, that participation, that it's meaningful, that it's fun, and that it's matched with routines. And this is actually he's G-tube fed. So he's getting his drink through his G-tube in the standing position. And I did want to let you kind of see that actually works out well in terms of access. And then this is transitioning between activities because it is so mobile. Monica says it actually feels easier to push than a wheelchair. And that way he can go to lunch already in his stander. So thinking outside the box and working with classroom staff to really make standing part of the child's school experience.